I try to always assume the best, meaning that the patient is in a vulnerable place, that we're coming to me for help. It might just be an innocent remark, or it might be the question behind the question might be, do you know what you're doing? Either way, it's okay. They're allowed to have that fear because it's their life, and they want the best for their care.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Welcome to season 5 of Parallax. Thank you for all the love and for all the support. As I've said in some of my previous episodes, Parallax is ranked at number 2 by feedspot.com. These are ratings which were published last year on September 2. And, we are really proud of where we've come. Certainly would not have been possible without the listeners, and certainly not possible without our phenomenal guests. One of which is on today's show, and this name certainly needs no introduction. We've followed her on Twitter, and we've really loved her rules, and we have garnered so much clinical insight into patient care and how to conduct ourselves as physicians and clinicians, through reading those rules on Twitter. And, she has gone a step further now and actually published a book, which I think is a phenomenal read. I'm actually reading it. I'm in the middle of reading it. I haven't read it completely, but it's a book which I haven't been able to keep down ever since I've started it earlier this week. So without much further ado, I'd like to formally introduce our guest on today's show, which is, episode 84 of Parallax, but it's actually the first episode of season 5. So Happy New Year to everyone. So my guest on today's show is Dr. Michelle Kittleson. As I mentioned before, this name needs no introduction. And she's a professor of medicine and cardiology at Cedars-Sinai Medical Center in California, and an advanced heart failure and transplant cardiologist. We've known her by hashtag Kittleson Rules on Twitter. And, I've been an avid follower of hers for several years. We've actually been wanting to do this episode for almost 3 years. I'm a strong believer that every occurrence in life has a timing. And so there was a timing to it, and it could not be perfect timing now that she's out with a book. We're going to talk about her book, which is Mastering the Art of Patient Care. But, before we get into the book, Michelle, thank you so much for doing this for us, and welcome on the show.
Thank you so much. I'm delighted to be here.
Oh, it's our pleasure. And, on the behalf of everyone at Parallax and Radcliffe Medical Media, congratulations on the book. As I mentioned in my introduction, I haven't finished it yet, but it's a book which I have not been able to keep down because it's written so well and it's organized so well, and the topography of how the chapters have been laid out is very methodical. But before I get to the book, the audience and the listenership would certainly like to learn more about your journey into medicine and cardiology.
Sure. Wonderful. I'll start, I suppose, at the end of the story, which is to say, I cannot imagine a better job, career, profession, vocation, however I can describe it, than being a physician. And it all started back, honestly, before I was born. I'm the 5th generation of physicians in my family. My grandfather was the dean of a medical school in Bangalore, India, St. John's Medical College. My parents met as medical students, and I was pretty much told from birth that I would become a physician. In the tradition of all good Indian immigrant families, my destiny was cast before me without much say for me. And like a good child, I listened to my parents, and it turned out amazingly. I couldn't have been from the first day of medical school. I was captivated by all this new knowledge I would learn. I ended up choosing internal medicine because I felt it was, for 2 reasons. One, the most incredible mentors I wanted to model myself after, and because I felt it was the most efficient knowledge use of everything I'd memorized in medical school. And I chose cardiology again because of incredible mentors and role models, and also because I loved the fact that in cardiology, the history and physical exam are so crucial to our understanding of what's going on with the patient. You can't diagnose unstable angina without a history. You can't diagnose decompensated heart failure without a physical examination. I love the power of that. And I ended up choosing advanced heart failure transplant cardiology. Again, mentors, a huge theme, the impact mentors have had on me. And because I loved the emotional fulfillment of seeing patients through this journey, as well as the intellectual satisfaction of being able to manage patients in the outpatient setting, the inpatient setting, the cardiac catheterization laboratory, the multidisciplinary approach to management. And so for all those reasons, I ended up where I am today, a dedicated clinician. That's my first and foremost role in medicine, is as a clinician.
Yes, and this is a testament that I've started reading the book, and that is that you've actually used that sentence you've written that in a book, that you can't diagnose unstable angina without a good history, and you can't diagnose acute decompensated heart failure without a physical exam. So, here's my testimony that I've actually started reading the book.
We'll do a quiz on reading comprehension at the end. Fantastic.
Yes, and fifth generation of doctors in the family is phenomenal, and I resonate with what you said, because I am obviously my father is a cardiologist back in India, in Delhi, and he's an out-and-out clinician. He's 72, will be 73 this year, and still runs a very busy, clinical practice, and is revered by his patients. And that growing up for me was my motivation to become a physician. And it's interesting you mentioned that your destiny was written before you were even born. This, as far as I can remember, certainly as far as I can go back into childhood memories, the only person that I wanted to be was a doctor. And whether we were conditioned in that fashion, I'm certain we were. It's hard for me to tell, but I think credit to my parents, and I certainly have not. I completely agree with you. Whether it's profession, vocation, however you want to call it, you're searching for each one of us searches for their own ikigai. That Japanese word of ikigai. And, I think being a physician and, a clinical researcher or a writer, as you are, has certainly been very fulfilling, for me. And I'm sure that resonates with so many of us. And I think it's important to share that message with the listenership, as well as with the audience, as well as, with medical students and house staff, because we do see physician burnout and physician suicide, all these topics making the headlines. It is important to also share that just the physician, being a physician aspect of the job is still very fulfilling for so many of us, right? Would you agree with that?
100%. And I have a theory that burnout, it's not about working hard. We all want to work hard. No, everyone loves getting into bed at the end of the day and feeling like you did something incredible, that wonderful feeling of exhausted fulfillment. So I think burnout comes not from hard work, because all good work is hard work, but from not feeling valued and appreciated, not having some flexibility and autonomy in your life. And so I think whatever profession one crafts for oneself, and maybe it will be medicine because there's such a gift to being in medicine, it is trying to figure out how you define your fulfillment. And for some people, it's people telling you, wow, you did a great job. And for others, it might be monetary compensation. For others, it might be professional advancement, honors, and awards. But knowing yourself, knowing what drives you, I think will help you have the greatest satisfaction. So I don't think it's about less hours. It's more about those other intangibles of how do you make the work meaningful for you.
Yes, I couldn't agree with you more. I think you have to derive meaning, and I really liked the term you used here. Exhaustive fulfillment. Is that what you said? Exhaustive. Yeah. Yes. I mean, I think at the end of the day, if you can go to bed and, um, certainly, I mean, I don't know if the listenership journals or if you journal, but I certainly journal, each night before I go to bed. And, if I can write down just three things which, I think went well, uh, on that particular day, it's a fulfilled day for me. And, the rubric or the verve of those things is typically, about the impact that I may have created, whether it's through writing a paper, whether it's through a conversation like this, whether it's, talking to someone on the phone, or, whether it's taking care of a patient. As long as I made some impact in some way, shape, or form through my action, that counts as a fulfilled day for me. And, that I think ushers in, like you said, it's a noble profession. It's such a privilege to be a physician. It ushers in a feeling of gratitude, which I think is really, really important to cultivate and practice, because if you don't practice, then the mind is such, a trickster that it always wants to focus on aspects of your life which are not perfect, whatever perfect means for you. So, I do think that it's important to cultivate that feeling of fulfillment, and cultivate that feeling of gratitude, and just be mindful of, things you say and conversations you have and actions you take, because you don't know how those words and how those actions impact the recipient. And, I think in medicine, we just are blessed to touch so many lives on a daily basis. And not only that one patient that we treat, but also their families and their loved ones and their extended relatives. And it just, the delta can go so far for each of us, which I think is so gratifying. Moving on, tell us, your clinical training and, some of the institutions that you went to for training, because you do bring that up, when, choosing, a residency position or a fellowship position, you do bring up the importance of, location, the importance of volume, and the importance of mentorship. So I do want to touch base on those aspects. And, at Parallax, we actually have, had, speakers talk about, the importance of mentorship. And I know you've had some fantastic mentors in your life who've shaped your career so well. So, talk to us about your training and your mentorship.
Amazing. Happy to do so. So my training, I grew up in Connecticut, went to a public high school there. I went to Harvard for undergraduate, where I majored in biochemical sciences, like every good pre-med is supposed to do. And then when I look back on my college experience, it's funny that the classes I still think about that meant the most to me were those required electives even a biochemistry major has to take. And I took one in opera, where we did Rigoletto, the Magic Flute, and De Valkyrie, and I still remember those operas to this day. And a class on poetry. It was called Poems, Poets, and Poetry, and I still have my Norton anthology of poetry from that class with my notes in the margin. So that was college. Medical school, I went to Yale for medical school. And then I did internal medicine at Brigham and Women's Hospital, and cardiology training at Johns Hopkins, where I also did the PhD program in clinical investigation, learning the nuts and bolts of the biostats and epidemiology that underpins clinical research. And when I think about advising trainees on how do you pick a program, I think the three most important criteria of medical education in order are volume, autonomy, and mentorship. And that would be chapter 3, section 3.4, where, volume means how do we learn? We learn by doing. Medicine is ultimately an apprenticeship, and the more you do of something, the better you get at it. And, I like to tell trainees, you want to see everything while you're still in training. You don't want to see it for the first time when you're out of training, if you can help it. So when you're looking amongst programs, high volume is so important. Autonomy is interesting. In a way, it's a relationship that every trainee will negotiate with every attending physician they work with. How much am I going to take? How much are you going to give? But sometimes there are cultural, programmatic autonomy standards, and you want to do the best to try to be the captain of the ship, to make decisions while you have the safety net of those with more experience behind you, supporting you. And when it comes to mentorship, there are those formalized programs where you are assigned a mentor. Sometimes to me, those feel a little bit like awkward blind dates. Are we supposed to have another one? Did we get something out of this? I think mentorship sprouts organically. And I talk in my book about fleeting mentors, where there might be someone you work with for half a day who influences your practice for the rest of your career. Or there might be people you use earlier in your career that you may outgrow. There's others who will stick with you for life. The litmus test of who can be your mentor is, number one, do you want to be like them when you grow up? And number two, are they willing to tell you about their journey? Because if you don't see a commonality, you want to be like them, then what use is that? And if they don't seem open to sharing things with you, then they're not going to make a great mentor. And there will be a cabinet. There will be your work-life balance mentor. There will be your clinical mentor, your research mentor, your professional advancement mentor. There'll be mentors you have that are more minimalist, those that are more proactive in their approach to patient care, and you will learn from all of them. So really, when I think about training, I think about all those people throughout my career who influenced me in small ways and big ways. I tell a story in the book about this ophthalmology resident I worked with. I was a fourth-year medical student. I already knew where I was matched for residency, but I just wanted to take some electives that weren't going to be too stressful. So I decided, ophthalmology, that seems pretty fun. And this wonderful resident took me under his wing, tried to teach me all about those unintelligible abbreviations they use, which I still don't understand to this day. But he did something really remarkable. We had to go in and examine a patient. And he examined the patient, and I examined the patient. And he said to me, whenever I examine a patient, when I'm listening with my stethoscope, I never go in straight with the stethoscope. I always put my hand on their shoulder to establish connection before I reach in to auscultate the heart or the lungs. And that connection, that resonated with me. And every time, now this is decades later, I still do that, and I think of him. So, you will find so many pearls of knowledge in so many places. And one of the goals of this book was, how are you, your mentors sometimes come down to luck. Who do you encounter? But it shouldn't have to be all luck. So by sharing here the wisdom I learned in so many phases of my training from so many different people, it's my hope that this book will function as a mentor for people who aren't lucky enough to meet all the people I did who taught me.
Yes, thank you for that response. I agree with you in that I think the burden of mentorship should not be put on one person's shoulders. I think you need mentors who will match different needs of mentoring. I think, and you sort of bring that up in the book very eloquently as well, that, there are some who are just great clinicians, and then there are some who are just great researchers and writers. And there are some who have mastered the art of balancing work and life. And I think you can pick the qualities from each one of those and seek them out, as and when you need them for that specific aspect of your professional life or your personal life. There are some who you just connect with, at a personal level, and, those relationships carry forward for the rest of your life. And, they become your life mentors, because they've sort of been through life, and different stages of life, ahead of you. And, as you may want to emulate your life, on their life, they can be an incredible resource, when you get to that stage of that, of your life, which they've already, traversed, and I certainly have, my own secret squad of mentors that I reach out to, every now and then when I need to just have this conversation with them. And I think these relationships are nurtured throughout life. So I couldn't agree with you more there. And just by the way, just phenomenal medical background and training. I think this would just be a dream for, I was going to say dream for any Indian kid, but I think dream for any kid, just to go to the places that, you've been to, like Harvard for undergrad and Yale for medical school, and, Brigham and Women's for residency, and then Johns Hopkins for fellowship. I mean, what a phenomenal training and background, and to get your PhD in epidemiology and clinical investigation just, adds that layer of physician, investigator, and a clinician, which I think is such a beautiful and important combination. Not only to be, I think, a researcher, but I think a great clinician. I think you do need to appreciate and understand. And I'm just going to bring that anecdote of you describing how when the sacubitril valsartan trial was published and you were at the airport wanting to board the airplane, and you were looking at the KM curves, and it had been so long, like there hadn't been a drug after AHEFT, which would have impacted mortality, like you mentioned in the book, in patients with heart failure. And now you see sacubitril valsartan on top of great background therapy, which was considered great background therapy at the time. I know since then we've now moved on to quadruple, background therapy for heart failure. But I do think that having that intrinsic inherent knowledge during training, for how to interpret these intricate data, and how to like just knowing the difference between, as treated and per protocol and intention to treat analyses, and looking at KM curves and interpreting them, based on how these analyses were done, and then applying them to your patients, I think is an invaluable skill. I think is important to know that skill, not only to be a good researcher, but to be a great clinician for your patients. Would you agree?
I think that's true. And the beauty of medicine, I think, is how wide open it is. And what I mean by that is, when I graduated from fellowship, I had this conception in my mind that my life is going to look exactly like it looks from when I'm a first year attending for the next few decades until I retire. And you always hear, I would always hear people more senior to me, the more experienced faculty saying it's a lifelong learning process. And honestly, by the end of fellowship, I was so burned out of learning and being overwhelmed and uncertain about my fund of knowledge wasn't where it should be, that I was like, I don't want to hear it's a lifelong learning process. I want to feel mastery. I don't want to feel uncertainty with my knowledge base. And for me, it was about 5 years into being an attending physician that I said, okay, I got this. I don't know everything, but I know what I don't know. I know when to ask the right questions. I know when to anticipate clinical scenarios. And at that point, and I was even better by that point at interpreting the clinical trials. So all of that to say that no matter what amazing place you do your training at, you will find those incredible role model clinicians to attach yourself to. And one of the beauties of social media is the flattening of the hierarchies and the geography, where you can have mentors that you meet through Twitter, of all places, where you can gain knowledge and make connections. And you find that as you gain that comfort, which really only comes from experience, I hope the pearls in my book help speed that along, so you don't have to make all the mistakes yourselves. You can learn from mine. But with that experience comes the comfort that you get, where you now understand the relevance. How does this clinical trial apply to my patient? So what is at one time overwhelming now becomes more comfortable as you and the incorporation of new knowledge, instead of being overwhelming, becomes exciting because you have a framework in which to place it.
Yeah, no, absolutely. Which actually does bring me to the next question. And that question is, and this is, I think it's particularly geared for medical students. And this is like the very first chapter. And that is how to learn, the verbiage of medicine and being in medical school. And I think the anecdote, I shouldn't say really the anecdote, but the allegory that you use there is you equate it to learning French, after you got back from France with your parents. And, I sort of, that resonated with me as well, because I learned French in school from 6th grade to 10th grade, and then went on to an exchange visitor program with a French family where we stayed for a month with a French family. And we were in a French boarding school for about a month. And then, the next year when I was in 11th grade, so in high school, that French family came to India, to be with us for a month in Delhi. So that really resonated with me. But, I think what happened was, as soon as I entered medical school after high school, because there's no college in India, but the medical school is roughly like 5.5 or 6 years. I actually, all the French that I had like taken boards in French. So that all that French actually evaporated, as I started learning medicine. So I do want you to discuss that aspect of the book and that allegory in particular, and, what pearls you have for medical students there.
Absolutely. I think there's no sugarcoating it. Medical school is hard. Medical school is really hard, and it is intimidating, and it is rewarding, but there's a lot of hard work to get you there. So when I have the wide-eyed college graduates on their way to medical school, they want my advice, I say, it's going to be hard, but if you know that going in and you have a system, you will be able to excel. So, and what is that system? Exactly as you said, it's treating medical knowledge like a foreign language. I love the fact that when you start learning a foreign language, and it's just all the drudgery of verbs and nouns, and is it masculine tense or feminine tense, and all that, and it becomes, but you stick with it, and then you can actually appreciate the poetry. And I think that same transition happens in medical school. My roommates and I would sit around the table in our apartment trying to pronounce words like supraventricular or postganglionic. I mean, these words, and I have to do it today with things like levetiracetam. I still have to do that. So there is this drudgery of memorization that cannot be escaped, because you have to know the basics. Now, I say in the book that medical knowledge is half at most of what it takes to be a good doctor, but it's still a large proportion of what it takes to be a good doctor. So you do the medical work, you accept that the drudgery will end in an appreciation of the poetry of medicine. So I think that point is so important. And I would argue that your knowledge of French, even if you forgot it, helped you in medical school. So I think it's always important in the sense that you have the ability to remember a time in your life where something was hard, felt impossible, unintelligible, but through dedicated work, effort, time, commitment, the impossible became possible. And I think when you're on the precipice of medical school, looking back at other times of your life when you were able to master something that felt impossible, will give you the strength to enter this new chapter, whether it's some really hard athletic thing. Of course, I cannot provide an example since I'm terrible athletically, whether it's a piece on the piano, whether it's a foreign language. You will remember your ability to master that and know that medicine will be the next thing that you will conquer.
Yes, no, just great examples. And I mean, I think the only thing that I remember in French now is "Je m'appelle Anker."
Very useful.
And I say to my son, "Je t'aime," and
yeah.
I mean, I could say "Comment vous appelez-vous," and I mean, I still have the pronunciation. So if I read it, I will pronounce it correctly, so I think that's still there somewhere, in the brain. And I still have the, like you said, the male and the female verbs, which is very unique to French, I think as a language. But yes, I think if you can, channel those skills of your gray matter and sort of, commit to rote memory, like we've written in the book, because a lot of things in medical school are rote memory, and you do mention about, some having photographic memory, and I certainly remember some of my colleagues who had photographic memory, and you would be like, why did I not have photographic memory to get into medical school? But I think those are some of the shared emotions that I think all of the medical students have experienced at some point, during medical school. Which actually brings me to the question that why. Well, first of all, thank you for writing such a beautiful book. Like I said, I haven't been able to keep it down. Between my two boys who are 5.5 and 3 years old, I'm still trying to get through this book, which is beautifully written, and so much of it resonates with my own life. I wanted to ask you about the motivation and the timing of when you decided to write this book. Was it something which you always wanted to do and you were just waiting for the right time, or was it something which you got inspired to do after what you started sharing on Twitter with Kittleson rules? And by the way, if for any of you who are still not following her on Twitter, which I doubt would be any, at least in cardiology, please follow her. And we'll have you tell us your Twitter handle to the listenership again. But when was it? Was it the success of #Kittleson rules that inspired you to write a book, or was it something that you always wanted to do? Is the question.
Yeah, that's a fantastic question. So it's at @mkittlesonmd, pretty simple. So my origin story of the book starts with an origin story about Twitter. I was never one for social media. I mean, I've never been one for technology. I remember being amazed that fax machines work. Like, how does this happen where I send a paper and the paper ends up miles away? I don't understand this technology. And then I was on rounds one day with one of my fellows, and I was, of course, mentoring him, and he became my mentor in the sense that he said, "You're always spouting these pearls on rounds. Well, why don't you put them on Twitter?" And I said, "No one wants to see selfies of me eating breakfast." And he said, "No, that's not Twitter. That's Instagram. The Twitter is more about medicine." I said, "I don't know. That sounds quite suspect to me." And then we were talking about a patient, and he brings up a study, and I said, "Wait a minute. I haven't read that study yet, but that was a really insightful commentary on it." And he pulls up his phone. He says, "Look, everyone's discussing it on Twitter." And I said, "Wow." So he helped me set up my account. And then I actually had Kittleson Rules predates Twitter. It was inspired by, there was that show on CBS ages ago called NCIS. And there was a mentor of sorts who ran this Naval Criminal Investigation Service team. And he would teach his proteges things, and if they got it wrong, he'd smack them on the back of the head and say, "Gibbs rule number 1" or something. And I don't smack anyone on the back of the head ever, not even my kids, but I would say, "Aha, I have Kittleson rule number 1," and I would just name these and go around. And so I said, okay, instead of just torturing the trainees who are forced around with me, maybe I should share these more widely. So that's how #Kittleson Rules was born, all inspired by this CBS TV show and the things I would say on rounds anyway. And that's my rule. If I'd say it on rounds, put it on Twitter. And, I was delighted, surprised and delighted by the reception. People seemed hungry for these facts. And of course, experienced clinicians said, "Of course, that's so obvious. We know that." But no one quite says some of these things explicitly. So I think people found it very helpful. And then people on Twitter would say, "Well, when are you going to write the book? And what's going to happen here?" And a shout out to, there's a Dr. Mark Reed, who's written a book called Medical Axioms, sent me a copy of his book when Kittleson Rules started, to say, "You should write something like this." And then Jim Januzzi, a cardiologist at MGH, said, "Listen, you better write this book before someone else does, and let me connect you with my editor at Springer." And that's sort of where it started. COVID hit, and I think everyone was mentally subsumed with the existential dread of COVID for a while. So I'd written an outline. So thank you for saying how well it's organized, because I love outlines. I wrote an outline and then put it aside a while because I was just trying to wrap my head around the life of my family and my patients through COVID. And then it was maybe early 2021 when life started to calm down a bit, or I understood where life was going again, where I'm an early bird. I get up at 4:30 every morning, and I would write for 40 to 60 minutes. I had my outline already. I knew what I wanted to say, just a matter of saying it. And I guess the rest is history, in the sense that that's how the book was born. My purpose was, I didn't want just a listing of Kittleson rules. Listen, you want those, you can go to Twitter. I wanted to say more than I could say in 200 some odd characters. I wanted to put the subtlety in there, the thoughts, the illustrative anecdotes, and I wanted it to be helpful no matter what one's area of training. So as you know, part one is about building your medical foundation. What happens in medical school? How do you poise yourself for success in residency? How do you choose your career path? And then part two about honing your clinical judgment. Like, how do you make these diagnostic and therapeutic interventions? In general, how do you view the role of a consultant? How are you the best consultant? And then part three is more of, okay, you've gotten there when it comes to the medical aspects, but how do you lead a team? How do you poise yourself to be most effective as a working clinician? How do you have those hard conversations with patients who don't agree with you, who are scared, angry, or frustrated? And then I conclude with part four, which is, how do you take not only great care of your patients, but of yourself? And I talk about being a woman in medicine and those self-care boundaries. How do you deal with grief and mistakes? So really trying to touch the lives of anyone in medicine, whether you're on the precipice of your career or whether you're in the midst of it, but not finding the joy that you could find if there's things you could control about your relationship with medicine. Can these tools, can these systems, can this advice help you?
Yes, no, I mean, I think the way it's written, and I'm just sorry for being repetitive, but it's the first thing which was so impressionable to me when I started reading it. I obviously looked at the table of contents, and I think just like I mentioned at the beginning of the episode, the topography of how well it was organized, and how you took us chronologically through medical school, your training, being an attending physician. And then I do want the last segment of the podcast, I do want to discuss the chapters that you've written, which I think are beautiful chapters, which I think one is about life during COVID-19, which I think is very relevant and timely. You have written a chapter on self-care, which I think does not only include self, it also includes care. I think many times people, when they think of self-care, they only stop at self, but they don't focus on care. And I think it'll be important discussion to have with you, because you bring up things like vacation time, you bring up grief and mistakes, you really dive deep. Like, this is like inner work or meditation. You dive deep into distinguishing the unforeseen from the expected. You dive deep into like control is an illusion, that and only focusing on things you can control, which is very, very relevant to how I live my life, on the principles of the Bhagavad Gita, which is you are only entitled to your action, and the chips will fall wherever they'll fall, and that's not your fault, as long as you can stand up and say that your action was well intentioned. So I do want to dive into both those two chapters, and then just a shout out for women in medicine. I mean, I think you've dedicated a chapter to being a woman in medicine, and the headline of the chapter actually has in parentheses, "Men don't skip this chapter." And really men should not skip this chapter. So, why don't we talk a little bit about being a woman in medicine and what experiences it has garnered for you? Let's start there.
Sure, wonderful. And you apologized before for being repetitive, but if you're going to repeat how awesome the book is, please be as repetitive as you like. I love it. So being a woman in medicine, I approached this chapter, I was raised on 3 immutable truths. One of which I already told you, I would become the 5th generation of physicians in my family. The second thing I was told, was that as a woman, I would be a minority in medicine. And the third thing I was told is I would have to work twice as hard as a man to be considered 1/2 as good. These are just, I was raised for that to be my expectation. And while there are certainly situations where I've been treated differently, I've learned when is it something I can change, and as you noted, when is it something where you just have to let it go? And of course, what I'm talking about here is one system. It's not the right system. It's not the only system. It's the system that worked for me. And the second thing I'll say is, I think there's a difference between hurtful microaggressions and the darker side of sexual harassment. And that boundary will be very different for different people. I am grateful to say I never experienced that darker side of being a woman in medicine. But I would say for anyone who has survived that, the key is to tell your mentor early and often. And if your mentor is not responsive, you escalate your concerns up the chain of command. Program director, department director, human resources. That's zero tolerance, swift action. But what do you do about the other situations? The situations where, for example, when I was an intern in the intensive care unit, sometimes the nurse would come up to me and say, patient's getting hypotensive. And it would always, I felt with chagrin how whenever I gave the nurse a response, I felt that they would look to the left and above me, kind of over my shoulder to where my resident was standing, and wouldn't say yes to my whatever recommendation I had until my resident standing behind me nodded their head. And I didn't like that. But then I saw there was a surgical intern who was a woman, and she was also small like me, Asian like me, and she would stroll into the intensive care unit, very polite, give a recommendation, and the nurses would follow it immediately. And I said, wait a second. It's not because I'm a woman. It's not because I'm small. Why is she getting the respect that I'm not getting? And I really kind of subtly stalked her, or eavesdropped on her conversations with the nurses. And I realized there was one big thing she did that I didn't, was that I posed all my requests in the form of a question. The nurse would say, the patient's getting hypotensive. I'd say, I think we should increase the norepinephrine. Whereas I should have said, let's increase the norepinephrine. And so part of the upward inflection, having confidence in my own recommendation, gave who I was speaking to confidence in my recommendation. Now, sometimes I wouldn't know. I'd go to my resident. But then in turning around to relay them, it's having that sense of, what about you? Can you change that can make the situation better? I think part of that is claiming your role. I'm pretty clear when I walk into a patient's room now and the patient is overwhelmed because there's 7 people now entering the room for rounds. Who is who? And so I'll say something like, I'm Dr. Kittleson. I'm the boss of the team, because I think that makes it very clear, because it's confusing. Everyone's dressed the same. Everyone looks the same. Now everyone's got masks on. Who's who? What is everyone's role? I think that's important. Sometimes humor and sarcasm can help. I've had situations where patients will say to me, but you look too young to be a doctor. And sometimes I say things like, thank you, my plastic surgeon would be so pleased. Or, the insurance plans here in Los Angeles cover Botox for doctors. And I think that kind of breaks the ice. And I try to always assume the best, meaning that the patient is in a vulnerable place. They're coming to me for help. It might just be an innocent remark, or it might be the question behind the question might be, do you know what you're doing? Either way, it's okay. They're allowed to have that fear because it's their life and they want the best for their care. That being said, I think you also know as a physician when to address the elephant in the room. So the elephant in the room can be where you truly feel as if the patient is treating you with disrespect. I have a patient, for example, every time I see him, I've known him for over a decade. He's one of my heart transplant patients. He does everything I said. He hangs on my every word. But when I walk in the room, he says, "Miss Michelle," and gives me a huge hug. Now, could I correct him and say it's actually Dr. Kittleson? Of course not, because it's the context I think about, not the label. But there are sometimes when the label is associated with a disrespectful context. And in that situation, I think it's really important to call out the elephant in the room. You seem uncomfortable with my care. Let's talk about why. If you'd rather not, let's find you a physician who might be a better fit. Now, better fit might be a demographic distinct from my own, but regardless, it's call out the elephant because it'll work out better for you and the patient. So I think that's certainly a part of it. And I think the other thing that's very important for women in medicine is how does your family life balance, your work family life balance? And there's a lot in chapter 11 that I talk about regarding my advice for how do you navigate parenthood as a physician.
For anyone who's interested, and you should be if you are in medicine, let alone cardiology, to pick a copy for this copy of this book. It's by Springer, that's the publisher, and it's called Mastering the Art of Patient Care, and it's written by Dr. Michelle Kittleson. It'll be worth your time. It'll be worth your monies, and I think you'll garner so much insight into what modern healthcare and modern life as a busy clinician taking care of patients and raising a family, looks like. Dr. Kittleson, any closing remarks for Parallax? Any closing remarks for our audience, our listenership? And again, I can't thank you enough for reaching out, and I'm so glad that in 3 years we've finally gotten this done.
Yeah, well, I am delighted as well. I think the final remarks are that there'll be highs and lows in your medical career, times when you're grateful for the privilege and time you question if it's the right career. And the thing that will make that process the most rewarding and the most fulfilling truly can come for the relationships you establish with your mentors as they help you to navigate the challenges ahead. And I hope this book functions as a type of mentor, a reference for difficult times in medicine to help you navigate those tough situations so you can derive the greatest joy from helping people and saving lives.
Well, that's a great note to end, the episode. And, thanks again for your time. And for our listenership, we truly value your feedback. So do leave us a feedback on, Facebook, Twitter, LinkedIn, whatever social media platform you use. You can also email us at the email address which is provided in the show notes. We are going to share the link for the book that Dr. Kittleson has published in the show notes as well as her Twitter handle. Like I said, if you are not following her, do follow her, and do leave us your remarks. We do read them carefully. We are very responsive to them, and we will get the guests that you want to hear from. So with that note, we'll see you back another Monday. Thank you.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.